technology in surgery, a global leader in vascular surgery. His name is Andres Schanzer, Cutler Distinguished Chair and Professor, Division of Vascular Surgery, Director, UMass Memorial Center for Complex Aortic Disease, Director, UMass Memorial Heart and Vascular Center, University of Massachusetts Medical School. Thank you for that.
Great, thank you. Let me just see if I can get this set up. Great, thanks so much for the opportunity to be here. It's really an honor, and it's very fun for me and actually humbling to hear these talks. Very different from many of the conferences I attend, and really inspiring work that's going on. It's also a treat for me to be able to see my co-fellow Tech Chong and hear the great work you're doing in Singapore. So today I'm going to try to tell a little bit of a story of the way in which I've been involved in some global collaborations around vascular surgery. These are my disclosures. They are relevant to this talk. I'll be talking about these different devices as well as these imaging modalities. So I'm going to try to frame this around the aorta. This is really an area that has been my passion, and that what I would argue has experienced some of the most aggressive innovation over the last couple of years. And since everyone's not a vascular surgery in this room, I thought I'd start with a little bit of background. So for context, abdominal AAA, 16,000 deaths annually in the US. It's a 13th leading cause of death in the US, and it's a 10th leading cause of death in men over age 55. I think most know the natural history. That's expansion followed by rupture. And we have pretty good level 1 data now to inform the decision on when to treat, at least in infrarenal aneurysms, which would be a threshold of 5.5 centimeters, and maybe a little lower at 5 centimeters for women due to the change in size. Now, we all know about open repair. This has been really discovered or elaborated on in the 1950s and really perfected over that time. And I think we can generally do that really well, and it's been shown to be effective and durable. But we've also learned that there's 5 to 10% mortality in population-based studies, 15 to 30% significant morbidity, recovery of 2 to 3 months, and I think what we often don't talk about are the high-risk patients that are denied repair. And it's really with that context that in 1991 there was a transformative moment. And that really started with 2 pioneers, one from Russia, one from Argentina, that interestingly performed these procedures within 2 months of each other, although they were published at different times, really first describing this idea of, instead of an open repair, doing an endoluminal repair. So endovascular AAA repair is important to understand that it's really a completely different paradigm than open repair. We work to exclude the aneurysm from the circulation instead of cutting it out and putting in a new prosthetic aorta. So the device is inserted from the groins, it's positioned with X-ray guidance, and then the aneurysm is excluded with a covered stent graft stent system. So 2 pioneers, Argentina, Russia, and then 4 years later brought to the United States by this group to New York City. And this really started based on an endovascular foundation that was laid by 2 people in the United States and 1 in Switzerland. I think many in this room will be familiar with the names Charles Dotter in the 60s, developing percutaneous angioplasty, Dr. Grunzig in 1977 in Switzerland with the first coronary angioplasty, and then really bringing those technologies together with a balloon expandable stent in 1985, Dr. Palmas. And with these innovative steps, the pendulum has swung quickly. So now, in the United States, over 80% of infrarenal elective repairs of AAA are performed utilizing EVAR. And one can ask the question, why? And we had the opportunity to expand on this a little bit in a couple of review articles looking at the differences over the last 2 decades with endovascular repair and open repair. And I think the best way to summarize it is really with this one table that takes a couple of the large randomized controlled trials. And what we've seen clearly is that when selected in the right patients, EVAR is associated with a decrease in mean operative time, decreased in estimated blood loss, decreased blood products transfused, decreased length of ICU stay, decreased overall length of stay, and this last line is what I'll really draw your attention to, which is a 5-fold reduction in perioperative mortality. So significant benefit. And I think the feeling was that if you take an open surgery like this that can be performed pretty well, and then add a minimally invasive technique that can reduce the mortality by 5-fold, then perhaps the true benefit is actually not in these infrarenal repairs, but in these more complex aneurysms that we often see. So about 30 to 40% of aneurysms, complex AAA with juxtarenal and pararenal anatomy, or even thoraco-abdominal aneurysms involving both the chest and the belly. Because we all look at figures like this and it looks super clean, super easy, pretty straightforward dissection, but when we do it in real life, it actually can be a pretty significant systemic insult to a patient. And when we look at the 3 highest volume, highest performing sites in the United States, you can see that for open thoraco repair, the 30-day mortality is not negligible, ranging from 7 to 16%. But perhaps what's more sobering is when you look out into the more general population, and this is a study done by my friend David Rakeberg from UCLA, looking at open thoraco repair in the California statewide inpatient database. And what they showed was that the overall elective mortality was 19% at 30 days and 31% at 12 months. So let me just kind of reiterate that. 20% 30-day mortality for elective surgery. Obviously, a lot of room for improvement. And that's what really had innovators thinking about new ways to take on this problem. And that's what really led to what's called fenestrated and branched endovascular aneurysm repair. And I'll just stop at these photographs for a minute because I think this is important to understand the rest of the talk. So what you see on screen left is a scallop. That's a cutout in fabric that allows you to bring a stent graft all the way up to a target artery. So you could imagine a kidney artery sitting right in that valley. The middle pane is a fenestration. Fenestra is Greek for window. It's just a hole in the fabric so you can bring fabric above and below a target artery. And then all the way on the other side of the screen are 4 axial branches, which now allow you to treat the entire length of the aorta if you're putting branches into the celiac SMA in both renals in this example. So where did this come from? Interestingly, really came from Australia. So there were 3 people, Thomas Brown, Michael Lawrence Brown, and David Hartley, who developed the Zenith endograft, ultimately purchased by Cook Medical. And then John Anderson, who was in interventional radiology on the other side of Australia, that took this technology, cut a hole in it, and published the first fenestrated endograft in 2001. And it's really with that foundation of technology that at UMass we set out to create our Center for Complex Aortic Disease. This really started with a vision in 2008, ultimately allowing us to get a physician-sponsored investigational device exemption in October of 2013 to evaluate custom-made devices and physician-modified approved devices for the treatment of patients with thoraco-abdominal, complex abdominal, and arch aneurysms. And we've been able to grow that volume, and we're now up around just under 600 cases, and we're the second busiest in the country and among the 5 highest providers in the world for this technology. We use patient-specific custom-made devices. So on the left, you see off-the-shelf devices. These are devices we can take off the shelf to fit to a patient, called the Cook P-branch or T-branch. But what we use much more commonly are these patient-specific devices, where we can work with some back and forth with engineers to tell them exactly how to build a graft to fit an exact patient's anatomy. We use fenestrations in different configurations, small and large, and then we use branches in a lot of different configurations, which really allow us now to fit a stent graft to almost any patient's anatomy. And with this technology, we've been able to contribute with lots of single-center reports. And with these single-center reports, I think we've been able to make some contributions. And nearly every one of these studies has had this sentence in it. These findings may be limited due to the potential for a type 1 error to limited, secondary to limited statistical power. And that's because the volume of thoraco-abdominal aortic aneurysm disease is just not high enough for a single center to really move the needle on the important contributions that need to be made. And that's why we worked to set up the United States Aortic Research Consortium. This is a consortium of 10 US sites, all running prospective physician-sponsored studies, independently monitored, FDA audited, with similar device designs using selective use of fenestrations and branches. And these are the 10 sites that have these PSIDs. And it's really with that I think these single-center studies from an individual site are really a thing of the past. And I think the future is really going to be these collaborations. So how did this start? Really, it started with an email in 2018 where several of our colleagues kind of decided to get together and start sharing some of our data. So we went to do that, and what we learned by looking at each site's clinical research forms is that we all defined everything differently. An MI at UMass was not the same as an MI at MGH. It actually was amazing to me to look through the list of variables, and almost everything was different. So we started a process where we met every other Monday for 2 years, going through all of our CRF forms, and we created basically a module in order to track a patient from initial evaluation through long-term follow-up. And it was a very organic effort. I mean, this is an Excel database. This one I think was from 2019. And we basically had 3 columns for every module. What were we going to call the variable, how were we going to define it, and how we were going to code it. And what I'll tell you, which is kind of surprising to me, is it turns out if you get 10 people that think they're the best in the world at doing something, it's pretty hard to get them all to change their ways to do it the same way. But ultimately we were able to do that. We engaged the FDA early, and they were very supportive of this effort. And that's really what led to what I call sort of the final product, the US Aortic Research Consortium 2.0. We created a memorandum of understanding that allowed us to hold each other accountable. We then created bylaws, so clear responsibilities for sites were established. And then we got external funding to create an electronic data capture system. So instead of sending around Excel databases, we now have a very easy to use, real-time data entry system. We have every piece of the journey, all the CRF forms in that. We've built in data quality queries to try to have the most robust data we can. We have a real-time data download system where you can download your own site's data, identified, and you can download the entire consortium's database, de-identified. We've been able to grow the volume significantly. It's now the biggest data set in the world for fenestrated branch endografts with over 3,500 patients and over 12,000 target arteries. And the feeling really is that working together, I think we can really bring this effort to a new level. And we've been able to contribute at several meetings around the world with publications in high-impact journals, looking at different topics related to how we can move the field forward with growing numbers of patients in this collaborative effort. And these are just some examples, but you can see that now we're getting into very large numbers where we can start asking really sophisticated questions. And I'll just highlight this one example. So now instead of having on the order of 500 to 600 patients, we can look specifically at 2,426 renal mesenteric artery directional branches. And instead of suffering from this power issue, we can now look, and I promise this is the only Kaplan-Meier curve I'll show you, we can now look at individual stent grafts and figure out which is going to be most effective in which vascular bed, and start really directing care so that we can improve outcomes. I'll just say as a high-level statistic, we've been really proud that we've been able to keep our 30-day mortality very low at 2.9%. And again, I put that in the context of these high-volume centers with outstanding results with open repair. So what are the deliverables from the US ARC effort? It's now the largest data set of fenestrated branch EVAR in the world. It's a core group of investigators committed to improving patient care and pushing the envelope on endovascular therapies from the aortic valve to the femoral artery. It's high-quality adjudicated data that's now harmonized across all sites. It's an engine for the exchange of ideas and promotion of these technologies, ideally within the US and across the globe. We've now created the infrastructure for a more agile regulatory pathway for testing emerging technologies. For the first time ever, the FDA is now using our ARC data for a PMA application for a new device to roll that out in the United States. It's a departure from single center reports. We've been able to standardize best practices, 2 examples here, how best to manage anticoagulation and antiplatelets around these repairs, how best to have a protocol for spinal cord protection. What I'm most excited about is we now have the infrastructure to conduct randomized trials at a fraction of the price. We just finished the United States ARC prophylactic versus therapeutic randomized controlled trial. That was piloted at 2 sites, UMass and University of Alabama, and now we're going to roll it out across the entire consortium. So what I hope you see is that it's more patients getting better care by more providers using fenestrated branch EVAR devices. And the obvious next step is taking this to an international level, so we've now expanded it to 26 clinical sites around the world. And it's really been fun to see that expand now with contributions on a global effort, looking here at extent 1 to 3 thoraco outcomes, looking here at staging strategies, looking here at chronic aortic dissection, and just one last example of failure to rescue, which was just presented a couple months ago. So let me just give you one example of what these technologies look like. So this is a 75-year-old man who was referred for degeneration of a known aortic dissection. 6 months prior to this, he had a type A dissection with an open repair and a subsequent left carotid subclavian and TEVAR graft. And he was found to have a persistent type 1A endoleak with further aneurysmal degeneration from 4 centimeters to over 7 centimeters. So here you can see this large aneurysm with a type 1 endoleak around the graft. Interestingly, he also had a bovine origin, so a joint origin of his left carotid and his innominate. But it was large enough that we thought, working with the engineers on these custom devices, that we could come up with a scheme to put 2 branches going out to each of those through that joint origin. So we worked back and forth with the engineers to create this graft. They then spec it out. We approve those specs and we build it. We're then in the operating room. Here you can see we've got bilateral percutaneous groin access. For this case, a right carotid cut down, left high brachial access. We then use fusion imaging, so what you're seeing there with the orange overlay, we're not using X-ray for that. We've fused the patient's imaging with the preoperative CTA, so we have a 3-dimensional roadmap. Here we're advancing the device, so you can see the device going up through the arch of the aorta. We then unsheath the device, so now we're opening it. The reason you're not seeing the aortic arch moving is because we're using rapid ventricular pacing, so the heart's beating at 200 beats per minute, so it stops movement and allows very precise positioning. We then position this innominate bridging stent graft, so you can see that being positioned. We then unsheath that and deploy it. So here you can see that we're pulling back the sheath, and you'll see that stent graft's opening in the junction zone there in the arch graft, and you'll see it expand here into the innominate artery. We then do a completion angiogram at that branch to make sure there's a good seal. We then repeat with deploying a carotid bridging stent graft. Again, another angiogram to make sure there's a good seal. We then do a completion image to show that there's complete aneurysm exclusion now. This patient had an uncomplicated postoperative course. He was discharged on postoperative day 1 with 3 months of Plavix. This is what his 1-month scan looks like. I'm not sure if this video is going to play. As you come down, and you can see good stent graft architecture with complete exclusion of the aneurysm. And I think most importantly, this is what the patient looks like 5 days out. And this is a patient that went home on post-op day 1, came back in 5 days out from home. I could show you pictures of his aorta, but I think just looking at him, you can see pretty impressive for the magnitude of the operation. But there is a price to pay for this, and these are the highest radiation-intense procedures we do across the spectrum of medicine. And I think what we've learned is that there's a concern for patients about the radiation exposure, but actually what I'm more worried about is not the patient that has one procedure. I'm more worried about the care team that does, this week I've done 3 of these procedures, I'll go back tomorrow, I have my 4th. So we're getting exposed to massive doses of radiation all the time. And I think we all know of some people that have had negative effects from this radiation. One of my mentors at the top there, Roy Greenberg, who developed a cancer thought to be radiation related. So it's really with that problem that a few sites, 4 in the US, 3 from Europe, have set out to really push this fiber optic real shape technology, which gets us away from our dependence on radiation. So this enables real-time 3D visualization of the full shape of devices inside the body without the need for radiation. So there's a catheter, there's a wire, it's got a fiber optic cable in it, and it's shooting light through 2,000 times per second. And what the computer on the other end can do is take any deflection of that catheter or wire and compute where it is in 3-dimensional space. So this is what it looks like in our OR. There's a workstation, an engine, and a docking adapter. And this is really just to kind of run you through it in a very abbreviated way, just to show you what this looks like. So here I'm plugging in the device. So I've got these catheters and wires that I'm handing off the cable. They're plugging it into that workstation. Now I'm registering it, so I'm letting the system know where the catheter is in 3-dimensional space relative to the patient. And now I've asked the computer to generate a 3D model. So the yellow is a wire, the blue is a catheter. We're not using any X-ray here. In real time, we're seeing this wire and catheter advance through the patient. In this case, you just saw it go out the SMA. Now it's going out the celiac artery. Next, we'll go to one of the renal arteries. Also, you'll notice that we're looking in a virtual biplane. We can look at as many projections as we want because this is all a three-dimensional model. You're not actually using X-ray for this. So you can look in all these different directions, which adds a lot of value as well. And then ultimately, we're able to do these very radiation-intense steps with no radiation at all and get the same type of result where we've got complete aneurysm exclusion. I put this in nearly every presentation I give. It's aspirational, but I do believe that during my career, all aortic pathology from the aortic valve to the femoral artery will be treated with stent grafts. And during my career, endovascular aortic repair will be performed without the need for radiation. There is a time we're going to talk to med students, and they're going to be like, so tell me again, you used to like stand right next to this radiation emitting machine and you just like hold down the pedal for a couple hours? Because that doesn't make any sense. It's insane, and we really need to get away from that. So we've come pretty far along. This is a patient who had really what we'd call mega aorta, so ascending aneurysm, arch aneurysm, infrarenal, the whole extent. We're able now to really treat almost all of that with branched and fenestrated stent grafts. And it's been exciting to be a part of this kind of global journey that's made this possible. I think in some ways, what's really sort of attractive about this is being able to do this with 2 Band-Aids from the groin. And while I would say that is amazing compared to what an open thoraco looks like, what's really amazing is what these patients look like afterwards. And this is really the magic. So this is a patient 7 days out from a redo endovascular thoraco repair, coming in from home, and you can see what I would argue is there is not a single patient that's ever had an open thoraco that looked like that at 7 days. And what's really nice is this is 7 days, but this is 7 years. And I think the question was, is this going to be a durable technology? And I think what we've learned over the last 20 years is that it is indeed durable. So this is a recent case we had, and what I'll show you is, again, really extensive repair, but there's one challenge, and that's this spot right here. So how do we get between the valve and the ascending? Because I'm told by my cardiology partners that the coronaries are very important. Well, let me tell you about a friend of mine in France. This is one of my really close friends. This is his case, not mine, Stefan Hallon. So he's been working to develop a graft that now can incorporate the coronary arteries. It's a mated thoracic graft with coronary branches that mates with an aortic valve. So you now use the aortic valve for fixation. So this is the concept. You draw a picture and you start working with some engineers. You then see if they can build it. You then have them build it and print a 3-dimensional model of the patient and then run them through a cone beam CT. So we actually deployed this endograft in this 3D model, did a cone beam CT to see how it conformed to this plastic version of the patient's aorta. And then you go to a patient. And here you can see that same device now being put in a patient with a branch to the left coronary, a branch to the right coronary. So I think hopefully what you can see is with this global effort, we really have come far along. And I think it's fair to say it's not really necessary to look too far into the future. We see enough already to be certain that it will be magnificent. So thanks very much for the opportunity to be here. It's really fun to be able to meet all of you. Thanks for your time.
What a wonderful talk there. We learned a lot. Collaboration and innovation. Really, you hit it out of the box there. So next speaker is Michael Teodulu. Dr. Teodulu is going to speak about end-stage ankle arthritis. We are moving on to different organs now. So he's